Good evening, everyone. Here Imran Abbas. Again, we are live on Global Laparoscopy, a group on Facebook and also on Zoom link. We will continue our series of safe sleeve gastrectomy, and it is great honor. Today we have one of the best surgeon from Mexico, Professor Raul Chapa. He is a well-known bariatric surgeon and with highly expertise in sleeve gastrectomy. Professor, this is great honor for me, for GLR TV, for our team, for global laparoscopy and robotics, to have such a legendary personality from that place of the world. So now we are live on Facebook group, Global Laparoscopy. Sir, highly welcome.
Hi everyone. I'm Dr. Raul Chapa from Mexico, and I be honored to among you. And thanks, Dr. Imran, for your invitation and this cycle of conference for about the bariatric procedures. In this occasion, I talk about gastric sleeve.
Sir, great honor, because we have started this series, because as you know, we have finished a series of MGB, OAGB, and there was a lot of response, and we had a successful sum-up session. Really, it was a great message for our youngsters. So then we have started safe sleeve gastrectomy, series of safe. We have started this series with Professor Patrick Noel, who is a well-known bariatric surgeon with a lot of experience in sleeve gastrectomy. And we will continue this series till December. In December, we will have a sum-up session. Sir, we will have repeated question in this series. Same, we will also ask some question, because at the end then we can sum up this session. So what is our target in this series and in this interview? Overall, this interview is in light mood, and you can share your knowledge, and especially in this COVID era, so this is the best way to share your knowledge and your experience. So in this series, and especially in this session, we will try our best so convey your message about safe sleeve gastrectomy, especially for youngsters. So how they can do the best sleeve gastrectomy with less complication. Sir, please, your brief introduction.
Yes, in my experience, I have 20 years. I started the bariatric surgery, and maybe 20 years ago, I have a lot of procedures in the time, like a lap band, gastric sleeve, it's a raid, gastric bypass, and one anastomosis gastric bypass and revisions. And I adopt this gastric sleeve procedure maybe 14 years ago, and I have a great expectative with this procedure, but in the time changed my opinion. But I consider it's very important, this kind of procedure, and the most important concept for me is the correct select this procedure for each patient. Consider many options, and it's very important. I consider in general that the bariatric surgery, the bariatric procedures should be tailored. Yes, it's very important for select each patient for each procedure. The gastric sleeve is a good procedure, and this cycle of conference, I developed the surgery, and any tips about the advantage, disadvantage, and complication, how to prevent the complication with this kind of procedure. The safe procedure is follow the rules. Follow the rules in the experience, in our experience, maybe 20 years ago. It's very important. First, select precisely select the patient. The good selection of the patient, like actually I perform this procedure in patients younger or elderly. Because why? Because it's good procedure, but you can increase or regain weight in the time. I consider this with this procedure 3 or 5 years with good evolution, but change after 5 years if you don't select the correct patient. You need to select very carefully patients with consider conditions.
Sir, excellent, demonstration. So, sir, so now I like to know about, because as you have mentioned, now more than 2 decades you are performing so bariatric surgery, and now about 14 years, so sleeve gastrectomy. So have you changed your technique during this period for better results? Sleeve gastrectomy.
Yeah, I changed in the time. Why? Yes, but in the initial stage, I consider is easy, is fast, but in the time I consider other change. Why? Because with the time I consider complications if you don't refine your technique. I include 3 very important tips. 1, consider the patient, consider device, and consider your technique. Consider the anatomic patient, anatomic structures of the patient, like history, record, and if the patient take a medication with a lot medication with PPI or antacid or analgesic for other problems like junction and other problems, you need to consider this option. If the patient found in the upper endoscopy, if you consider or found carcinoma or Barrett and other conditions, big hernia, diaphragm hernia, I consider is not the best option. Device, what kind of device? Device of the cartilage, brands, everything. Another condition is your technique. Your technique is very important. Consider good exposition, instruments, good communication with your anesthetist, with your assistant, with your instruments, and all the people in the surgery room.
Sir, excellent. So this is a great message for our youngsters. So selection of the patient for sleeve gastrectomy. If patient is under treatment with the chronic, due to chronic disease and need more pills or tablets, then a sleeve is better chance, because maybe sometimes you will face there is malabsorption of this medication. This professor so highlighted this point, and also Barrett esophagus, this documented reflux and large sagittal hernia. is not a good candidate for a sleeve gastrectomy. Sir, excellent. Sir, regarding your personal practice, so which percentage of your bariatric surgery belong to sleeve gastrectomy?
Sleeve gastrectomy, I consider in my practice 20 or 30%. Why? Because I consider in the time and other options. Yeah, other options depend on the patient, the needs of the patient and the indications. What is the for the beginners, the surgery beginners? Why? It's very important to consider relative or absolute contraindications. Yes, for the gastric sleeve. What is the total or a very complete contraindication for this patient? If the patient found in the upper endoscopy, found carcinoma, Barrett, big hernia, or another conditions, if the patient is have a problem with coffee, tea, tobacco, and other conditions like a preference for the spicy foods, it's very difficult. This kind of patient, if the patient have another condition like a lung failure or heart, very important severe heart failure, is contraindication. If the patient have diabetes type 1, is not good election. If the patient uncontrolled treatment with diabetes, it's not a good option for this kind of patient. What is the relative contraindications? Relative contraindication is if you have a patient with a lap band, yes, and remove the lap band simultaneous in this surgery to change to gastric sleeve, you can have problems with the leaks if you don't select your very well or very good cartridge, the size, consider the thick or thin tissues.
Sir, excellent. So again, this is a great message for our youngsters. If you are facing a patient for redo surgery after gastric band-aid, so because the thickness of that area, if you will do simultaneous sleeve gastrectomy, there is more chance of leak. So if you are going to do sleeve same time, so this is a risky procedure. Sir, excellent. Sir, we like to see your technique. If you have any video, short video for sleeve gastrectomy tips and tricks, please, sir.
Yes, wait a moment. Yes, share my video, sharing.
Yeah, you can share. So you can click here. There is a share a screen. You can see. Yes, now you can click and we can. Yes, I can see, sir.
Yes, thank you.
Welcome,
Okay, start the surgery.
Yeah.
I
Sir,
yes.
click.
I start the surgery with 5 ports, yeah, 5 trocars. This is an epigastric trocar, 5 millimeters. Is to retractive Nathanson retractor hepatic leaf, and consider the area. Another is other trocars is in the upper right and left, 12 millimeters for the stapler, and supraumbilical 10 millimeters, and the other is in the flank left, 5 millimeters. And consider start with a great curvature. This is a device of a harmonic scalpel or another brand like Ovidian, etc. And consider the area and the advance, the ligature, the up and the downside, and this cartridge is 60 millimeters, like purple, and consider communicate with the anesthesiologist like a bougie. I prefer 40 French. I tourist is French, and you the bougie and consider and to separate the stepper line 1 or 2 centimeters wide for to it's able to invaginate with suture and to prevent basically hemorrhage and control of homeostasis of the stepper line. And advance you can use with the 60 millimeters cartridge, purple, like a Covidian brand, or Johnson is another color, like a green, but in Covidian it's I consider is good. Purple cartridge. You can use 60 millimeters, or if you have available 45 millimeters, is considered two. And I consider to separate 1 or 2 centimeters. When you hew the bougie, consider the distance 1 or 2 centimeters is the distance like I recommend for you for is that's possible in vagina, the suture stepper line, and to prevent problems like hemostasis, hemorrhage, etc. This consider is the tube. It is very important appear in the posterior stomach, see the posterior wall of the stomach, and to prevent twist and other complications. Select, consider, plane, and stepper line 5. To advance, every stepper line 5, you need to check anterior and posterior stomach to prevent twisting. This is step by step. It's a short video.
Sir, what is the size of your bougie?
I prefer 36 French, 36 French.
36, but as you have mentioned, so your sleeve will be little wider. It will not kiss to or tight to bougie because you will imbricate and also for reinforce your stepper line. Am I correct?
Yeah, I don't use another material like butyricine, another for cost-effective reasons. And our country is considered safe and is very expensive. Another material like a butyricine to prevent the hemorrhage. This consider the upper stomach, the fundus, and consider I need to recognize 1 or 2 centimeters of the left sclera for the cut with the cartridge, and then we suture the upper stomach, imagine the stepper lane, and to prevent the hemorrhage and control of the hemostasia.
Sir, have you any experience of omentopexy in such a case?
Yeah, but it's not in all my cases, but it's a good option, like control, and it's like recover the anatomy, but it's not in all my patients.
Yeah.
Yes. What kind of suture? I use suture the Prolan 2.0, and with the circle needle, and the control of the hemostasia with the bougie. It's a control, stitch by stitch. And you consider the control of the hemostasia with this maneuver. In this point, I recognize the distance, the very important angular incision, maybe 3 or 5 centimeters distance to prevent constrictions. Yeah.
Sir, excellent. So you have mentioned 1.5 centimeter that EG junction, that was the point for our youngsters, and also as well as this incisor angularis. This is the point where stricture will come. So this distance is very important.
Yeah, it's very important. You need, when you beginner in this kind of surgery, you need to identify 3 anatomies structures, like a junction, angular incision, and the pylorus. If you identify these structures, you can do it a good principle for this kind of surgery. And then when you finish the running suture, I have a test with blue test methylene to check leaks and perfect close the line, stipple line, and the control of the hemostasia. And you need to check the stomach, maybe 80%, and I retire the stomach with the upper quadrant, left quadrant, and check, don't leak, only blood, and check this point, and when you finish, put a drain. Why drain? Because the drain to prevent check the least leaks or hemorrhage, to check when you use anticoagulant therapy. You can see or have an idea about the evolution of this patient. When I finish this procedure, the patient go to the recuperation room, and then maybe 2 hours after, go to the room, and then check and recommend for the nurses that my patients, please, 4 or 6 hours after the surgery, start the walk. It's very important to prevent thrombosis in the legs and pulmonary thrombosis, and consider to evaluate the drain and then other day, the next day, we check the patient with X-ray test with hydrosoluble contrast and X-ray department, like this. And swallow the drink with hydrosoluble, and this can, and I can see that's correct. No problem, no leak, no obstruction, and good evolution for this patient.
Sir, excellent demonstration. Please stop sharing. You can stop. You can click stop sharing. You can see, yes, there is a upside. You can see, yes, you can. Okay. Sir, excellent demonstration, really. And it was amazing. So every patient, you prefer to do this upper GI or barium meal to rule out any issue after sleep. Then you will you start PO for the patients. And also, as you have mentioned, in all of your patients, you prefer drain. So it's a great message, especially for our youngsters at initial stage. If they have any concern, so drain is always supportive, and also they can check any type of leak or any stricture before going to start oral liquid diet. They can do so this meal, so barium meal test. Sir, I like to ask a question regarding preop endoscopy and H. pylori eradication. So what is your suggestion? What is your routine practice?
Yeah, in my routine practice is not in all the patients the endoscopy, but when I found Helicobacter pylori in upper endoscopy, we need to treat first with amoxicillin and metronidazole and PPI, and control 1 month after, before the surgery, consider. The first is eradication of the Helicobacter pylori, because increase the complication and other kind of condition like a gastritis, reflux, and other problems if you don't eradicate the Helicobacter pylori. Yeah, it's very important, the upper endoscopy, but not routinary in our patients. I consider very important the upper endoscopy if the patient say me about I take PPI chronic and I have a reflux, a history, and other problems, conditions, history of the Barrett esophagus, everything.
Sir, excellent. So, so regarding post-op surveillance of endoscopy, so because as you know, one of the main issue after sleeve gastrectomy is GERD. So are you follow your patients endoscopically after surgery? Is it routine, all the patients? And what is your routine, sir?
Yeah, after the surgery, you need to consider the reflux GRD. I in my when I started to adopt this procedure, maybe 14 years ago, I remember some patients with chronic reflux, uncontrolled reflux, and ending in the bypass, gastric bypass. You need to already find the study of this kind of patient, what patient is for the gastric relief and what patient is for the other surgeries, like to prevent reflux or big hernia. It's better on bypass, gastric bypass. Yeah.
Okay, sir. So regarding this, because you follow endoscopically after surgery, now more than 1 decade, you are following these patients. What was your common findings after sleeve gastrectomy? Endoscopic finding.
Barrett, chronic reflux, problems with esophagitis, gastritis, chronic gastritis, to refractory to the treatment. And then we need to convert to gastric bypassing roads.
Sir, which percentage of your patient was suffering with esophagitis? I am not talking regarding Barrett esophagus, just esophagitis. If you have you any data, so which percentage of your patients after sleeve gastrectomy was suffering with esophagitis?
I consider some patients, but it's very important to follow the patient. What kind of follow? After the surgery, immediately our patients start the food with liquid, clear liquid, jelly, tea, juices. But after the patient increased the solids in her diet, and it's very important to follow this patient to prevent and recommend don't smoke, don't tobacco, don't take coffee, spicy foods, everything, and take your medication for 1 or 2 months after the surgery. It's very important to follow these patients. If you don't follow correct, you have many problems with the patients.
Sir, a patient, a morbid obese patient who is a heavy smoker. Okay, yes, you have talked with him and you know better than me. So these heavy smokers are little difficult patients. So what will you do? Are you go for sleeve or other surgeries, or you will not attend such a patient? What is your routine practice, sir?
Yes, I have many persons in my team. Yeah, I have a medical doctor, internist, and a gastroenterologist, and simultaneous check the patient and follow with the patient. With the I have yes, I have in my team pneumology. And pneumologists follow the patients with the recommendations like therapy for to prevent nor smoke or low the frequency of the smoke.
It's good.
Remember that the patients after the sleeve gastrectomy that's possible have another kind of complication. What kind of complication? Like the thrombosis. Yeah, it's a dramatic and big problem. Thrombosis, portal mesenteric thrombosis. It's very important to explain of the patients. This kind is the patient follow with bad habits like smoke can end in thrombosis, and thrombosis is a very dangerous condition. It's a lethal condition. It's very important to communicate with the patient and be very clear concepts of complications with these patients, and recommend to for the good healing in the stomach is very important. Consider as the don't smoke. Don't smoke decrease the flow and you can have problems with the cicatrization and the wound.
Sir, this is great message for youngsters if they face such a case. That is the routine in our practice. If there is someone who is a heavy smoker, so this psychological consultation, psychiatrist consultation for cessation of this smoking is very important, because smoking is really major issue after any type of bariatric surgery. Sir, in your practice, definite now about 16 years, you are 14 years you are practicing this sleeve gastrectomy. Have you faced any, also you have mentioned, so some intractable GERD after sleeve gastrectomy, and you have change to Roux-en-Y gastric bypass. So how many cases you have changed to Roux-en-Y gastric bypass due to intractable GERD? One question. And same now, what is your suggestion for our youngsters? So which technique they must do to prevent this intractable GERD after sleeve gastrectomy?
I prevent this kind of infections to educate for the patients. To educate for the patients, the correct communication, involve the patients with the patients, the communication. We in our team, I check the patient every week for 3 months. It's a very close the relation with the patients, and to prevent anything, any finding with the problems, infection, fever. If the patient have an obstruction, vomiting, headache, everything. Yeah.
Thank you, sir. So these are the points. So also already you have showed your video. So there was some points for our youngsters. So stricture at incisor angularis is very important, and the distance from EG junction is very important. That straight and symmetrical sleeve gastrectomy is very important. Sir, my question regarding technique: have you any experience of this gastroplasty with Corura to prevent migration of this sleeve to mediastinum? Are you prefer or no? There is no role of gastroplasty.
Yeah, I think it's a good option, because to prevent the slippage of the upper stomach to chest. But I don't use this technique. When I recognize a little hernia, resolve the hernia with 2 or 3 stitches to calibrate with bougie, 36 bougie, and check it's okay. Oh, that's right. But the technique, the gastropexia, it's a good technique, but I consider, in our experience, I check before very well the patient. If I identified the mid like 3 or 4 centimeters hernia, or more than 4 centimeters, I don't consider the gastric sleeve. And I consider is if you have a patient with a little hernia, 2 or 3 centimeters, like a hernia, you can repair, and I think it's no problem. But it's good option. But in my practice, I don't use this technique.
Thank you, sir. Thank you, sir. So as you have mentioned, so if there is a hiatal hernia more than 4 centimeters, that patient is not good candidate for a sleeve gastrectomy. So definitely you have faced leak after sleeve gastrectomy personally, or in your with your friends. So definitely you have faced such a nightmare situation or disaster that I can ask. So now, what is your suggestion for our youngsters, that technical points? So what is your that suggestion for our youngsters, what they do technically to prevent leak after sleeve gastrectomy?
For prevent,
Yeah.
yes. When the strategies to prevent leaks is very important. Consider the factors, anatomical factors. Yeah, anatomical factors like junction, angular incision, and pillar. And the other, correctly select the cartridge and measures and kind of the cartridge and of your device. Another is your technique. Your technique is very important uh, to prevent leaks. Don't use like a bougie. I I know about surgery. Surgeons use theory, but in my case, in my opinion, it's not good. It's because you don't have more tissue. If you need to invaginate, or if you need to other stepper line fire, you can do it if you use 28, 30, 30 bougie. I consider 36 bougie, and if you remove the lap band, and 6 months after remove the lap band, you can use the maybe 38 or 40 bougie use for to design your gastric sleeve. But it's very important to select each patient for each condition.
Yeah, sir. So yeah, yes, sir. As you have mentioned, so after gastric banding, at least 6 months, as you have mentioned, then you can go for sleeve gastrectomy. But because gastric banding is also a restrictive procedure, so when this procedure fail, or you prefer to go for any malabsorptive procedure after gastric banding? What is your preference?
What is preference about this
Redo surgery after gastric banding.
gastric banding? If the patient have a gastric banding and remove, maybe I consider other option, no gastric sleeve. What option? I consider simultaneous. I consider the one anastomotic gastric bypass for me actually, and be honest with you, with your audience. I convert the lap band to one anastomotic bypass or gastric bypass in J rods.
Thank you, sir. Sir, one of the I think disaster I can ask after sleeve gastrectomy is portal vein thrombosis. Have you experienced such a situation, and how can we prevent portal vein thrombosis after sleeve gastrectomy?
Fortunately, no, I don't have experience with my
You are lucky
patient
man.
in 20 years, but yeah, it's fear. It's a dramatic and terrible condition, but it's very important. I remember an article in obesity surgery published in 2017 about PMBT. PMBT is a portal mesenteric venous thrombosis, and recommend to prevent this terrible condition, recommend 4 days after the surgery, 4 days with anticoagulation therapy, and recommend to the patients maybe for 1 month, don't smoke, please. Should be don't smoke.
So, in your opinion, the most
Or
one of the most common cause of such a situation is smoking.
yes, I think it's very important to prevalence, high prevalence in the clothes and with the veins of the legs and other conditions. Is a contribution for the thrombosis, the pulmonary thrombosis and other kinds of complication when you smoke. And it's very to associate the tobacco use when with after surgery of the gastric sleeve, increase the possibilities of the, is to consider, you need to consider high prevalence or frequency and PMBT.
Yeah. Sure, sir. One of the issue after any type of restrictive procedure, especially sleeve gastrectomy, is dehydration, because the patient cannot drink, and routinely we discharge the patient. So just first day after surgery or one night stay, are you suggest, because in patient cannot tolerate liquid diet, are you prefer IV therapy, any serum 2 or 3 days after surgery? What is your routine practice to so prevent such a situation, dehydration after sleeve gastrectomy?
In our team, we recommend about dehydration is very important factor to decrease the complications, and can use maybe 1.5 liter per day or until 2 liters per day.
So if patient,
when the patient have a problem with the oral ingestion, we need to check on the hospital and put the liquids the vein, parenteral vein, and check for the better the kidney function and general irritation.
Yeah, sir. Thank you, sir. One of the main issue nowadays after sleeve gastrectomy is weight regain. So, which percentage of your patients are suffering with weight regain after sleeve gastrectomy?
It's very important your question. I think so maybe 50%. 50% is very important. When you don't select very well your patient, you have many fail. 50%. 50% maybe regain the weight in 5 years. Yeah. I think this is very important and very good option of the surgery, bariatric surgery, the gastric sleeve. But if you select very well your patient, it's a good option. But if you don't select very well, you have a failure and the patient is frustrated.
Sir, you have mentioned, so patient selection is very important. If you will not select the patient, there is more chance of weight regain. Just I like to highlight this point, weight regain. So which case is not good for sleeve gastrectomy, and there is more chance of weight regain after sleeve gastrectomy? Like grazer, like sweet lover. So
yeah, in this procedure is very it's good, but to all the successful depend of the correct select of the patient. But in others compared with than others surgeries like one endoscopic bypass or standard gastric bypass is better. Is the percentage of the average of the successful is this is better.
Yeah, thank you, sir. Sir, another issue, and also that is the most common nowadays, if you attend any international conference, so someone who are against sleeve gastrectomy, they highlight GERD after sleeve gastrectomy. So which percentage of your patients, definitely, you have mentioned earlier, so if patient is symptomatic GERD and a patient is suffering with esophagitis, you will not go for sleeve gastrectomy, you select your patients. Now, what is my question? After all of these MDTs, patient selection, everything, standard sleeve gastrectomy, everything is okay, fine. But again, your patients are suffering with GERD after sleeve gastrectomy. Which percentage?
I think when you select correct, maybe 80 or 90%.
No. 80 or 90% are okay. There is no GERD, or I don't understand.
Yes, successful.
80% are success. Maybe 20% of your patients, after all of these, following these criteria, these guidelines, patient selection, again they are suffering with GERD. And from these patients, so if we see, so but how you treat these patients when they are suffering with GERD? What you do for these cases?
Recommend general study and recommend maybe other procedure.
Yeah. But palliative therapy, palliation like PPI or so this change of lifestyle and dietary habits, is it effective?
Yeah, it's very important. It's very important, all the concepts. The surgery is good, but the change in your life is very important. Change your life. Yeah.
Sir, one of the procedure that recently started is SASI. Maybe you hear about that. Maybe you have no experience of SASI. So in such a case with the GERD, are you prefer to do SASI or no? You will go direct to Roux-en-Y. If a intractable GERD after a sleeve gastrectomy, directly you will go for Roux-en-Y gastric bypass. Which procedure you prefer? OAGB, Roux-en-Y gastric bypass, or SASI?
I use very common the one of small gastric bypasses. Maybe 2 weeks ago, I participate in the meeting in Mexico, the international committee about the gastric bypass, and I consider the mini gastric or one anastomosis gastric bypass is nice and very important option for the patients.
Sir, it means so then in near future, so this anastomosis gastric bypass will replace Roux-en-Y gastric bypass as an anti-reflux procedure. Are you agree?
I consider depend on the correct selection, because with one anastomosis gastric bypass is good, but if the patient have intratable or uncontrolled reflux, we need to convert a traditional gastric bypass.
Sir, really appreciable. So regarding this weight regain, so what is my question? Weight regain after a sleeve gastrectomy, so there is no symptom of GERD, only weight regain. So have you experience of re-sleeve in such a case? Nowadays, are you prefer? in 2021?
Uh, uh, Honestly, and actually, I don't use anymore the lap band, and only in select cases I recommend the gastric sleeve. I prefer the other procedures like anastomosis bypass or traditional bypass. I I learned in the time that is better in general condition, diabetes, hypertension, hypertriglyceridemia, and other conditions. For the reflux, it's a very important topic, but I consider other option.
Sir, what is your opinion about band-aid sleeve gastrectomy? Nowadays, Phoebe and Mohit Bhandari, they have started. And have you any opinion about band-aid sleeve gastrectomy to prevent this weight regain?
The band-aid gastrectomy is I learned in the time that don't use more foreign bodies.
I understand, because still
that's simple. That's
yeah.
I respect all my colleagues. Maybe things different of me, but I, in my personal opinion, I prefer don't use strange body.
Absolutely agree, sir. So this foreign body, always foreign body, and still we are facing that issues of gastric bending that I did about 15, 16 years ago. And till yes, we faced some issues. So regarding this endoscopic gastroplasty, so nowadays in market, Professor Galvao is in. So have you any experience? What is your opinion?
Yeah, I respect. It's a friend, the Dr. Manuel Galvao. It's a great doctor in the United States, Latin America, around of the world, and he's a very brilliant mind. But I respect the job of the Dr. Galvao. In my opinion, I don't consider endoscopy gastrectomy.
Yes, sir, really, it was a great honor. So to have you for at least now 1 hour and a lot of information, especially for our youngsters. So how can they perform safe sleeve gastrectomy? You have mentioned many technical points and also have mentioned that 3 areas are very important: distance from pylorus, distance from incisura angularis, and distance from each junction, that, and also that you imbricate or plicate your staple line and reinforce with stitch. It was amazing. Sir, your message for our youngsters who are just now going to start a sleeve gastrectomy, what they must do, please, sir.
Yeah, I recommend the correct selection of your patients. Why? If you consider the record and the history and communicate clear with the patients and select very, the selection is the most important for me. Remember, this is like a suit tailored.
Sir,
Every surgery, like every bariatric surgery, is like a suit tailored. It's in my opinion.
Yeah. Sir, really appreciable.
The message.
Yeah. It was a really great honor for our team, for GLR, Global Laparoscopy and Robotics, because your participation at our platform, it was a great honor for us. And hopefully our youngsters, especially they take this message, how they can perform safe sleeve gastrectomy. Sir, again, thanks, and definite we need your support and guidance, because after sleeve gastrectomy, we will follow Roux-en-Y gastric bypass series, then so metabolic surgeries in low BMI, and at the end in 2023, so we will follow redo surgeries. Sir, special thanks from our GLR TV, our team, and Global Laparoscopy.
Thank you. Thank you very much with this opportunity, and Dr. Imran Navas and your audience. Thank you for your attention. And
Sir, great honor, and also thanks our viewers, because without your support, we cannot continue such a academic activities online. So definitely we will continue our series of sleeve gastrectomy that we have started with Professor Patrick Noel, and this series will end in December. At that time, we will have a sum-up session. We need your suggestion, we need your questions. If you have any question, you can write in comments, and definite we will respond. And live stream also you can ask question. Sir, again, thanks. So, sir, in here in our area now midnight, and I think at that side of the world, maybe now afternoon, or I don't know which time in Mexico. So have a nice time, and our viewers have a nice time in the globe. Thank you, sir.
See you. Thanks.
Thank you, sir. Have a nice time.
Have a nice day.
Thank you, sir. Thanks a lot, sir.